So this is a recap of the ABO and all the carbohydrate antigens. For details, you'll want to look at each individual lecture, but this is kind of just summarizing everything and then highlighting everything you'll need to know for your ASCP exam. So we'll go over ABO and H, Lewis and secretor, the I, big I and little I antigens, and the P1, PK, and globicide blood group systems and antigens. Remember, all the carbohydrate antigens are not direct gene products. They are all created. The gene produces a transferase, which catalyzes the production of the antigen by adding a sugar to an existing carbohydrate chain. All the carbohydrate antigens have a common precursor structure. This is an antigen building block that is a lactosyl ceramide. There's the type 1 that is in body fluids and secretions, and then the type 2 that is primarily on red blood cells. So don't be overwhelmed by this image. I just really like it because it ties everything together. Remember, they're all starting with that common precursor, and then they branch out to form their own antigens. ABO, the original blood group system. It is the most important of all the blood groups in transfusion and transplant medicine because those antibodies are naturally occurring. Remember, there are 3 genes that are responsible for the ABO antigens: ABO, H, and secretor. Okay, the ABO antigens are detectable in utero around 5 to 6 weeks old. They reach adult strength when they're about 2 to 4 years of age. You will need to know the H antigen expression, so just memorize this chart. So O cells have the most H antigen expression. They'll react strongest with anti-H. Then we have the antibodies. Predominantly, ABO antibodies are IgM, and they are naturally occurring. Anti-A and anti-B are not present at birth. Remember, that's why we do not do reverse typing on newborns or cord blood. And the antibody are normally present around 3 months to 1 year, but they don't reach full adult titers until 5 to 10 years of age. So when you're studying for the ASCP exam, remember you will need to have a basic understanding of the ABO biochemistry. You'll need to know how to resolve ABO discrepancies, and you'll need to know the relationship between secretor, ABO, H, and Lewis antigens. Moving on to the Lewis blood group. This is ISBT 007. Lewis antigens are a little bit unique because they are not intrinsic to the RBC. They are on those precursor substance 1, so they're in secretions, and then they get absorbed onto the RBCs. There are several Lewis antigens, but the 2 primary ones are Lewis A and Lewis B. And there are 2 alleles for the Lewis locus, which is capital LE and then lowercase le. Same with secretor locus. There's the SE, capital S, and then there's the lowercase SE. In both cases, the little e and the little c, or sorry, little s, are amorphs, so they just do not produce anything. The synthesis of Lewis antigens depend on 2 genes, FUT2 and FUT3, which is secretor and Lewis. So I really like this image right here. It'll tell you exactly if Lewis is present and secretor is not present, what do you have? And for each different category, what do the antigens look like? So if you are Lewis negative and you are secretor negative, you will just not have any Lewis antigens and not have any H antigens in your secretions. And if you are Lewis positive and non-secretor, you will have Lewis A present. However, if you are Lewis and secretor genes are present, then you will have Lewis B. So just look at this image. I think it's very nice and explanatory. So remember, we have those three FUT genes. FUT1 is what makes H on the RBCs. It adds that fucose to type 2 precursor substances. FUT2 is a secretor gene. The transferase adds the fucose to type 1 precursor substance in secretions. And then FUT3, which is Lewis, that transferase adds a fucose to type 1 also in secretions. So the interaction between Lewis and secretor will determine if you have Lewis A or Lewis B. So if you have Lewis without secretor, you'll only see Lewis A activity. If you have both Lewis and secretor alleles, then you'll have the presence of Lewis B. Keep in mind there will still be a little bit of Lewis A floating around in your secretions, but primarily you're going to see Lewis B. And then if you do not have secretor or Lewis genes, then you will be Lewis A and B negative. So Lewis antibodies, they are made by Lewis A and B negative people, and they will often produce both antibodies. The optimum reaction is at room temp, but it can also react at 37 degrees. They're usually IgM, but sometimes they're IgG. There's very rare transfusion reactions. Usually these are just annoying antibodies that get in the way. You can neutralize them with Lewis substance, and anti-Lewis A is very common in pregnant women. And most of these antibodies are naturally occurring. Enzyme-treated cells do enhance the reactivity. So how do we deal with these antibodies? Usually they're not clinically significant, they're just annoying. So we will give cross-match compatible blood, and then we can sometimes use pre-warm technique to get the interference out of the way. On to the I antigens. These are closely linked to the ABO-H antigens. The type of cold reactive antibody produced is related to the ABO blood type, and this is related to the expression of A, B, H, and I on the red cell surface. So here are the two structures. You see that the big I antigen is just the branching of the little I antigen. This is a nice little chart to show you how much H and I are on each type of red cell. So when we have a cold reacting antibody, we can perform a mini cold panel to identify what antibody specificity is. These normally involve cord cells and reagent cells. Cold antibodies can cause problems with ABO typing. However you resolve the antibody screen, you can use that method to also resolve the ABO typing. For example, you have a forward type of A and a reverse type of O. A cold autoantibody can cause those extra reactions in your reverse typing. So you can pre-warm all your screen reagents, and that will cause the screen to go negative. Then you can use that same method with your ABO reagents. So you can do your reverse type with pre-warmed reagent cells and then pre-warm your patient plasma, so you can get that reverse type to come back out as a type A. Again, these antibodies are usually not clinically significant. They're just kind of annoying to deal with. So when you have a transfusion, you might just want to use a blood warmer. And the P1, PK, and globicide antigens. We have the P1 PK blood group system, which is 003 ISBT. It has three antigens, P1, PK, and NOR. The globicide blood group system, it has two antigens now, the P and PX2. And then you have Luke, which it got moved over to the high prevalence 901 series. You don't need to memorize this chart. I just find it very helpful to kind of see the structure of things. When you understand where everything is building upon, it makes it a lot easier to understand all the relationships. So there are lots of phenotypes. The most clinically significant one that you need to know is the little p, because they do make a clinically significant antibody. We'll talk about the phenotypes on the next slide, but you might want to come back and look at this picture to help you really understand what's going on with the phenotypes. So if you are P1, you will have P, P1, and PK on your RBC. You will not make any antibodies. P2 will have P and PK present, so they can make anti-P1. P1K has P1 and PK, so they can form anti-P. P2K has PK only, and they will make anti-P and anti-P1. And then the little p has no P1, PK, or P antigens, and they will make all the antibodies. So this chart is just kind of a different way to look at the last slide. The thing that's important to think about is the P1 phenotype, they still have PK, but they usually won't react with the anti-PK because they're just kind of being covered by the P1. So now we'll talk about all the antibodies related to these systems. Allo anti-P is a rare antibody because the P frequency is greater than 99.9%. So if that many people aren't negative, you're not going to have that many people making an antibody. The transfusion reactions are rare because the cross-match would be incompatible, so you wouldn't give that unit to someone. HDFN is not likely, and it is known to cause spontaneous abortions in little p mothers. Auto anti-P is the cause of PCH. It's a powerful biphasic IgG hemolysin. The test for this is the Doneth-Landsteiner test, where you incubate the cells at 4 degrees, kick it up to 37 degrees. If there's hemolysis, then that is a positive test. Don't confuse PCH with PNH. And this is more common in children than in adults. Anti-P1 is found in P2 individuals, and it is almost always naturally occurring IgM antibody. It reacts best colder than room temperature. It rarely binds complement, and it can be neutralized. It does not cause HDFN, and you can just give cross-match compatible units to these patients with this antibody. Anti-P, P1, PK is a naturally occurring antibody in little p individuals. It does not require stimulation to produce. It reacts at room temp, 37, and AHG, and it is a potent hemolyzer. It can cause spontaneous abortions and severe transfusion reactions. So that was a quick recap. Take a look at all the individual lectures to really build on your knowledge about all these systems.